Today, we want us to discuss a couple of things that are happening. We've seen non-communicable diseases on the rise in the country. We have a report in government hands that shows that we have a mental health crisis in the country. We know that cancer is a crisis in the country. The number of cancer cases in Kenya, cancer is the third largest cause of death in Kenya. More than 47,000 new cases diagnosed every year. Less than 30% of cancer patients accessing treatment. Many of them starting treatment and stopping even before they finish. Why? Because they cannot afford. Cancer treatment is costly. It goes into millions of shillings. Many cannot afford. And that's why we're having this conversation. I have with me a number of people, and I'm going to introduce them from my closest to the farthest. Dr. Lalit Varatpande is a medical oncologist from RFH Healthcare, and he'll be talking to us about his perspectives on how we deal with cancer cases in the country. We have Dr. Nathan Mulure, who's the head of government and public policy at Terumo Blood and Cell Technologies. Do we have enough blood in the country? They will say that yes, we do. But where is it? It's in our bodies. Okay, yeah, that's where it should be. But if you needed blood today in an emergency, how does it get from that donor's body to your body? Do we have it enough in the blood banks? And what can we do to improve that? That's what Dr. Mulure will be telling us. We have a mental health issue in the country and substance abuse. A report released just last month, I believe it was last month. It was February, April. It was in February. At the UON was showing that university students are actually now just casually abusing drugs and substances. Counseling psychologist from Nakada, Teresa Mwangi, is here, and we'll talk about this as well. And then we have Edwin Kegode, who is the general manager for managed medical care at Minet. Karibuni sana. And I just want to throw it out there, starting with you, Teresa. We have a mental health crisis in this country. And then we see it manifesting in substance abuse, and we also see substance abuse leading to mental health issues. Now at Nakada, you have a mandate, and we pay you people to make sure that you do this. What are you doing? What is it that Nakada has been doing to, first of all, make sure that you're spotlighting this in government circles at policy level?
Thank you. As the National Authority for the Campaign Against Alcohol and Drug Abuse, we have been putting initiatives in place to ensure that we are able to sufficiently handle the issue of alcohol and drug use among the general population and even among the students. You have rightly put it that it is worrying and shocking that the statistics that were released recently on the status of substance use among university students is worrying. And as the authority, we are now embarking on a conversation with the university management, university students, the security sector, and even the local community, just to try and find out what we can do and involve all the stakeholders in order to try and mitigate the effects of alcohol and drug use, especially among the university students. It is worrying to see that 1 in every 2 university students are currently using alcohol. So it means that the number is growing. And as Nakada, we are doing the much we can. After the release of the studies, we are conducting regional forums, including the university students, the university managements, to come up with strategies that are tailor-made to address the issues of alcohol and drugs, especially in our universities. Again, among the general population, there is a problem. And as you have rightly put it, the issue of mental health conditions is looming in our country. And one of the contributing factors to the increase in mental health conditions in our country is actually the use of alcohol and drugs. And many a times you find that people use substances to try and self-medicate, especially when they have a mental health condition. And at times, the use of alcohol and drug use also leads to the onset of mental health conditions. So as an authority, we are in the forefront, campaigning, carrying out public education and awareness creation to bring this to the attention of Kenyans, that look here, the use of alcohol and drugs is actually messing up your health. And in the mental health space, we say there is no health without mental health. Once you have lost your mental health, you almost have lost everything. But there is still hope, because most of of the mental health conditions are actually treatable and manageable. So it is something that can be addressed and people can get relief out of it.
Teresa, just want to, twist the knife a little bit and see whether you're going to bleed. The government comes up with stop campaigns, and you can come in the rest, where we see, okay, so we're going to have a crackdown on illicit alcohol, and then you're not addressing why are people buying illicit alcohol. It's because this other alcohol is out of reach for them. Okay, why are people heading into substance and alcohol abuse? What are economic factors contributing to this? How is this affecting security? We only see crackdowns from the government. I do not remember seeing a campaign where they are saying this is the situation, for example, in our informal settlements, and this is how we are going to encourage to give opportunities for the youth to stop heading into drug abuse. What is NACADA doing to advise the government that the way you're thinking 1972 and we're in 2025?
Thank you. Actually, we are taking a shift in the way we conduct our campaigns. Like I said, after the release of the university, the status of the university, status of alcohol and drug use in our university, among our university students, what we are embarking on is public forums, so that we get to hear what is it that is driving our students to drug use. And part of the recommendations from that study is that students and those who took part in the study are also suggesting a review of the law. The Alcoholics Drinks Control Act of 2010 provides that the 300-meter rule distance from learning institutions only takes care of basic institutions. That means kindergartens, primary schools, and secondary schools. However, the law assumed that the university students are adults, and therefore it never took cognizance of the fact that having to also include them in that part of the law would also be helpful in a way. So that is one of the recommendations, that now alcohol selling outlets is a recommendation that should actually be at least 300 meters away from university and colleges. And part of what NACADA does is to also take part in the review of the laws control the issues of alcohol and drugs in our country. Right. We also formulate policies, and we are now part of what we will do out of the public forums is to also assist universities and other institutions to also develop policies that will assist in terms of also regulating the issues of alcohol and drugs. The other thing from the survey is that partly, most of the students that also are mostly affected are those that live off campus. So again, we are also working with the university management to also try and find out how is it that they can also assist in terms of accommodating the students within the campuses.
Okay.
Thank you.
There's going to be a lot of debate on that even going forward. Even if you removed alcohol spaces from within 100 meters of a university student, my friend, it's all about wellness, which is why I want to bring in Edwin Kegote, who's the GM for Managed Medical Care at Minet. Edwin, wellness is something that Minet is big on, okay? But then, because you are an entity that is trading for business, is only wellness focused from your side only for those that are paying you for your services? Or how can this also be expanded so that we talk about wellness, not just in boardrooms or in offices, but wellness across the board?
Yes, thank you for that question. And indeed, as you mentioned, that awareness programs are first geared to support the clients that we have in our insurance book, but that does not limit us from availing wellness to the larger public. So I would like to say that, for example, we have a program that supports the mental wellness of our clients that allows that service to be extended to family members who may not necessarily be undercover, in such a manner that if a family has gone through some trauma and would like to get wellness assistance, then we extend that service to them. We also have outreach programs where we go into the communities to provide health checkups, assessments, and in that, members of the public are also encouraged to participate.
You know, when we talk about health now in general, there's what we always say. I mean, the goals for universal health coverage is accessible, you know, in terms of distance, and also accessible in terms of cost, right? Accessible, affordable, quality healthcare. Article 43 talks about the best attainable quality, right? Yes. Now, let's talk about that. From what you see as Minette, you're big on insurance, you're insuring people. Talk to us about the costs of healthcare, and then we shall talk to an oncologist who now is dealing with the other side of the heavy cost of accessing healthcare.
Okay, the cost of healthcare, as we have seen in the recent days, has continuously increased, and the reason for that is a myriad of issues that contribute to the cost of healthcare. First is the availability of the service across the country. In some parts of our country, we have limited health facilities, and therefore you find that the few service providers that are available in that region may harden the rates. However, that notwithstanding is that at Minette, we have endeavored to engage with medical service providers who deliver healthcare at what you'd call the last mile. And in that, we engage with them to agree on reasonable packages so as to save costs for the entire scheme. And in that, then, we bring in aspects of sustainability of health programs such that employer groups are able to then budget sufficiently and avail healthcare services to their members. So one of the critical things really is to engage and negotiate with medical service providers. We pride ourselves to be the largest insurance broker in the country, and therefore we leverage on our economies of scale to be able then to negotiate better rates. And when we negotiate for better rates for the insured population, it translates also to the larger population, because then the medical service provider is accustomed to these lower rates and can extend them to even cash payers, therefore making healthcare affordable.
How can we fix it more widely? So that now, for example, when you're moving a conversation into non-communicable diseases, people know of those ones that they talk about the lifestyle diseases, but there are other diseases as well. Screening, awareness, preventive, promotive. How can we do better in ensuring that we are handling prevention and promotion health better?
I think one is by increasing awareness that people need to know that health screening is an important aspect of managing their health. And therefore this awareness is should be encouraged across board, both from the private sector and the government side, to enable our members of the public aware that they need, at a certain age, these are the kind of tests that you need to partake. If you're a gentleman, a PSA test is important. For example, once you cross the 40-year mark. For a lady, certain tests are important that will then help in screening the third killer disease, as you mentioned, cancer. So just awareness is a first step towards availing information to people, but as well structuring packages with healthcare providers that will then provide these screening services at affordable rates for those that visit service providers. But beyond that, also putting out outreach programs in the communities where you go and set up health screening programs, even into the interiors and the ASAL areas, so that those who possibly are suffering from certain conditions can be brought to the fore, and you start managing that pretty early to eventually reduce the total cost of treating the patient when the disease has increased.
Thank you, Edwin, and we'll come back to you on this conversation. We'll shortly also be joined by Dr. Rizwana Pierboy, who is the General Manager at Lions Site First Eye Hospital. We'll also be talking about, that side as well, Site First, and what they're doing at Lions. I want to come to you, Dr. Bharat Pandey, medical oncologist at RFH Healthcare, still talking about now cancer as a burden. Many people are coming to your facilities at advanced stages of their cancer. So diagnosis is coming in and it's already advanced stages. That means that there's a challenge here in the screening stage. What is that challenge?
Good morning, everybody. Thank you for having me here. So, like you informed, we diagnose 45,000 cancer patients in a year in Kenya, and almost majority of them, 30,000 succumb to the disease. And it has been shown that 70% of these patients come to the doctor when the disease is locally advanced or advanced where cure is not possible. So this is because of various reasons. Most importantly, lack of awareness, lack of proper screening. So it has been estimated that 30 to 50% of cancers can be detected early. And when you can get away with simple treatment if you do screening. And the most common cancers that we see in Kenya are cervical cancer, breast cancer, and prostate cancer, for which effective screening is available. I mean, the studies are clearly shown that they reduce cancer-related mortality. But unfortunately, many patients, they don't undergo screening. And there was a study done by the Kenyan government a few years ago where they found that the uptake of cervical cancer screening was only 25%. In the age group of 25 to 35, the most vulnerable age group. So most patients end up coming to the oncologist when, the disease is really advanced or, in stage 4 where we can't cure them. And they end up having more complex treatment, which is more costly. And I think there's a lot of unmet need about cancer screening, lack of awareness, stigma associated with cancer. People fear to see the doctor because of cancer. They have heard of a lot of things, lot of myths are surrounding cancer. So I think social media can play a major role. Everybody has got a smartphone. We can inform people about cancer, its management, its screening. So a lot of things can be done.
A lot that needs to happen as well. Dr. Nathan Mulure is also here. He's the head of government and public policy at Terumo Blood and Cell Technologies. We'll be coming to you, Dr. We've also been joined by Dr. Rizwana Pierboy, who's from the Lions Site First Eye Hospital. We are live at the KICC at the Nation Health Summit. We want to take a quick break and then we come back and continue this conversation in the panel. There are very many things to talk about in health. We cannot finish it in this one panel, and that's why we are here until 10 a.m. discussing health. From this panel, we shall take it and expand it into a baraza. Please come and join us at the KICC. It's free entry at the Nation Health Summit. We'll be back in a moment. Whenever we are at the Nation Health Summit live at the KICC, come and join us. I'm here, Eric Latif, Mariam Bishar, Janet Bogwa. Janet and Mariam are organizing our next 2 hours, which are going to be very heavy, where we have a digital baraza. Janet, what do you have?
Right, so, this summit theme is towards a healthier nation, and I think that's what every one of us is trying to get towards. We've talked about blood transfusion, we've talked about cancer, we've talked about the issue around drug abuse and alcohol abuse. So how are we actually charting a future towards a healthier nation? That's what we want to achieve. We already have a few people around us. I think Mariam does as well. Somewhere back then she'll be able to tell us. So I think hopefully we'll be able to get towards understanding how do we collectively move towards a healthier nation? How does it take experts? How does it take those of us who are also seeking information? How do we break the access barriers? Because those are massive across all of the different health issues. So I'm hoping this can be teachable for the experts, for the public. And again, it's free entry. Please come to KICC. There's free screenings all day, a lot of free screenings, and we'll give you that information later on. So yeah, Latif, that's what we're hoping to do. So I'll throw it back to you later on. We'll have a conversation with some of the public members here.
Indeed, we shall be moving into that entire baraza. For now, let's have a conversation with my panel, which is comprising of Dr. Lalit Bharatpande, who's a medical oncologist at RFH Healthcare. We have Dr. Nathan Mulure, head of government and public policy at Terumo Blood and Cell Technologies. We've got Teresa Mwangi, counseling psychologist at Nakada, Edwin Kegode, general manager, managed medical care at Minet, and Dr. Rizwana Pierboy, who's a general manager at the Lions Site First Eye Hospital. We are talking about all these areas of health. Conversation starts here, and then it continues into the mic ground. So the mic now is going to Dr. Nathan Mulure at the Terumo Blood and Cell Technologies. We talk about blood, but we seem not to understand the issue of blood. Earlier, when we were talking about the conversation that we're going to have today, Mariam was like, I remember doing blood donations and blood drives when I was in high school. I also remember the same many years prior to that. I'm sure you also did the same, Dr. Mulure. We don't appear to be seeing more of that. Or Now we are seeing more and more cases of blood appeals, and we just don't seem to understand. Is it that we don't have enough blood in our blood banks?
Thank you very much, Eric, and good morning, everyone. Yes, indeed, you touch a very key point on blood. Blood is a big problem in many African countries. You find that very many countries do not have adequate blood. So I think we need to tackle blood from a very fundamental point of view. And the first one is that we don't have enough donors for blood. Very few people are donating blood regularly. So we need to do a lot of public education for people to understand that it's important to donate blood. I know very few people actually have been educated in terms of knowing who can donate blood, who can receive blood. People think that you can donate blood only once in your lifetime. The answer is no. You can actually donate blood every year. You can donate blood 3 times for men, for women, and for ladies, every year you can donate blood 3 times. So I think we need to impact the public with the knowledge about blood, for them to be able to come and donate blood. You find that today we have a lot of blood shortages, and you have rightly put it. I'm in a WhatsApp group today, and you find every morning appeal for blood.
Yeah.
Oh, we need A negative, we need O negative, we need O positive. And you find that circulating to a lot of people. But still patients are not getting this blood. So we need to fix the problem. The first problem to fix is education. People have to be educated about blood. We need to know that you can actually go to a blood center and donate blood. And blood is required for many things. I think we sometimes forget that blood is essential in terms of medical practice. And you find that you don't give that a lot of attention. And because of that, there's lack of funding for blood, there's lack of donors, there's lack of infrastructure to take care of the blood situation. So we need to start fundamentally to ensure that there's enough blood by educating the donors to give enough blood, and also to ensure that facilities are able to store this blood and also have the equipment to process this blood and transfuse it appropriately.
Do you have enough sufficient blood banks spread across the country?
Yes, we have a good infrastructure. We have the National Blood Bank at the KICC Hospital, near the KICC Hospital. Also have the regional blood centers, 6 of them. And we have very many satellite centers. So I think in that kind of spread, they're enough. But what we lack actually is the public education in terms of awareness creation. Very few people donate blood, and you find that sometimes blood banks run out of stock. At times we have blood, yes, but they're not testing kits, like that has happened some time back. You saw that in the media. And that lack of ecosystem prevents blood from being sufficient in the public domain. But I think if we do a lot of effort and also involve the government and the public, we can reach to points where blood is sufficient in this country. Yeah.
So, if you just take an example of Nairobi,
Yes.
Huge population with access to various health facilities just in Nairobi alone, and you're saying that we have a national blood bank at KNH. So why do we see so many blood appeals?
Yeah,
and patients
yes.
appearing to be in an emergency situation in need of blood?
Yes. Yeah, the demand for blood is very high. Demand is high, supply is low. And so we need to increase supply across the country, not just Nairobi. There's a blood requirement for cancer patients, for example. Cancer patients require platelets, they require a lot of blood transfusion. Sickle cell patients, malaria patients in this country, there are very many. So the demand for blood is so high. And also you find that when you have major accidents, again, blood runs short. The big accident has happened, 14 people are dead, maybe 28 are injured. All these need blood. So there are these upsurges that demand blood very acutely, and that makes sure that blood then is not available for other patients. So I think we need to collectively work on the blood situation, blood scenario, to ensure blood is available in adequate supplies in this country. Yeah.
Dr. Varakpanda, do you, from where you sit as somebody who is now treating cancer patients, like he says, you need a lot of blood, right? Is it about awareness, or does it go beyond awareness on the need for blood and the access to blood?
I think for me personally, availability of blood on time is the biggest stumbling block for treating my patients. So if I get a patient with anemia and I advise blood, so it takes anywhere between 1 or 2 days for the patient to get transfused. So which is not at all acceptable. So As he mentioned, this lack of awareness, people should be motivated to donate blood. And I think each hospital should have sufficient infrastructure to process blood and blood components. It's very important.
All right, so I want to now talk about eyesight as well. And you do more than that at Lions, right? You do a lot more than eyesight. But just starting with that, there are very many people who just assume when it comes to mambo ya macho is, secondary. First thing is we deal with these are bigger things, and mambo ya macho is secondary. Do you see that as an attitude that cuts across the society, starting from policymakers to communities?
Thank you, Eric. So basically, to a certain extent, I think the awareness has increased a little bit because, as you've seen, the use of technology has brought about awareness. But of course, in the underserved populations, sometimes it's lack of knowledge, and sometimes it's the myths and the cultural things where if your eyes are having a problem, you tend to give it a second seat, saying that I've aged and things like that. So, I mean, it's still, very prevalent. And even in the city, if people can't see, they might struggle with it, or they might just pick up readers and try to, make do with this. But a lot of times what we are seeing and what we are encouraging, just like everyone else here has said, is education and awareness needs to be increased, and our basic programs have to be strengthened, because by the time they're talking about having a problem with their eye, the root cause is somewhere else. So in fact, that's one of the reasons why Lions then did put up the Diabetes Comprehensive Center, because a lot of times they're coming to say that their eye has a problem, yet you check their sugars and that is what the cause is, and by then they've already hit initial retina damage.
Okay. In fact, just draw for us that connection. For many of the people who come to Lions and in other places, they're coming with shida ni macho. That's what they think, that's what they see, pun intended. But it's other things that cause it. What are these other things? And how can that be prevented?
So, well, basically, one of the biggest ones in the non-communicable disease space is diabetes. A lot of times, people are not tested, especially, in the underserved populations. They're in denial. Maybe it's the food, the kind of, carbohydrate-rich food that they get, and obviously because of their economic conditions, this is what they probably eat. So you find that they've had diabetes for a long time. Now, left untreated, they will come because now it's hit their eyes and the retina is giving them trouble. There are bleeds and new vessels formed and things like this. So they come to get that checked, now only to realize that the root cause is diabetes. Similarly, as they say, the eyes are a window to your soul. So a lot of investigations from your eyes will also point to things like conditions of the kidney, conditions of the heart. So if you do have a regular eye checkup, or if we can educate enough or even build comprehensive structures where medical checkup focuses on this, this might help to prevent not just eye disease, but also the other diseases which might be the root cause of having a problem with your eyes.
Is our public health structure organized in such a way that it picks up all these things in that ecosystem? When you go into a health facility, that they would be able to actually pick out all these issues in the various ways? Are we structured that way? Starting with you, Dr. Rizwana. Dr. Rizwana, let's start with you, and then I'll come to Eden.
I don't think it's necessarily structured that way. Like, essentially, a lot of times what will happen is you will be given an approval to cover for your eyes, yet maybe things like early screening in diabetes are not covered, especially with our universal health coverage. It's not necessarily covered, as you know, that they will cover more. In our case, they're covering only surgical procedures. So what we have then introduced is that if they do come in for an eye checkup, we are checking blood pressure and sugar stat at a minimum to make sure that we have trapped it if it's come, because it's very important that we address the main issue even as we're trying to sort out the eye problem. So you find that our core structure doesn't have this built-in. People generally have this mindset that you go and see the specialist for which you have the condition. And unfortunately, I don't think our multidisciplinary approach is as strong, which would probably help to give more support to patient care and general prevention. I will give you an example. There was a student that we received having persistent headaches, so put on glasses, given Panadol and all that, but the child was persistently complaining of headaches. So they decide now that they want to come and see a specialist. And incredibly, this child had an onset of glaucoma with 30% nerve damage already. 13-year-old.
At 13?
At 13. So that's why, in fact, now we're trying to encourage, where we're trying to create awareness through social media and other platforms, where we're saying right from age 0, if it's a premature child, you need the eyes checked. We're trying to engage with pediatricians. Likewise, at age 5 before school, we're trying to advocate, and we run a schools program as well, where we're going into schools, of course, so that we would be able to provide this support.
Edwin, coming to you at Minette, I mean, this is about insurance. Insurance is cost of healthcare. And as insurance companies, you want to minimize the outlay in terms of your cash. But also at the same time, you want to make sure that your clients and others in the population are as covered as much as possible with the little that they put in with their insurance. That means that the things that Dr. Rizwana has raised, and even the others have raised on the panel, early screening, early testing, early detection is critical. What do we do? And that's wellness. What do we do to improve this awareness on wellness?
Yeah, thank you. And glad to be part of this panel and just listening into what Dr. Rizwana has talked about, where the indicators that she's speaking is that there could be underlying conditions that eventually lead to these eye issues and many other issues across the panel here. At Minette, we run wellness programs for corporate schemes, and in there we embed health risk assessment, which is a critical aspect of just having a comprehensive screening of an individual. That is a benefit that we endeavor to embed in most of the schemes that we run, and therefore provide that opportunity for the principal members, the employees of a scheme, as well as their dependents, which would include children, to be able to get health screening. So health screening is a critical component of just arresting these things early. You talked about awareness, and I think in the current day and age where technology is available, we have endeavored to utilize technology much more than we would previously. So a lot of health nuggets that we send out to our clients and even to the general public, and therefore giving them topical issues from time to time, mostly around the World Health Organization calendar, to try and sensitize them about emerging conditions, emerging issues, emerging challenges, and therefore constantly putting in the mind of the population that health screening, health tests or health checkups is an important aspect. We have also taken a step further to bring health checkups at the doorsteps of our clients. So we organize for open days where we do screening, just as Nation Media is doing here at KICC, where we take this screening to the doorsteps of our clients and therefore provide that opportunity for this screening and picking up of possibly underlying conditions. I would say the government has a role to play in this space, and glad to hear that there is a rollout of the community health workers, which is an integral part of the ecosystem. Using the community health workers, then we can increase the awareness in the communities. We can increase screening of non-invasive kind of tests, like blood sugar tests and others, and therefore pick up these conditions that could be in the community and direct them to health centers where they can get better advice.
You know, the level 1 health facility in the country is a CHP, right? The community health promoters, and we have them now across the country, are we feeling the impact of community health promoters who are supposed to be kitted to go and do just those basic tests, to create awareness in the community, to encourage people to go for screening, for regular checkups and all? Are we feeling the impact of this? anyone can take the question. I can start with you, Dr. Mulure.
Yeah, thank you very much for that question. Yes, it's been a very good endeavor for the government of Kenya to include community health promoters, CHPs. And I think from the blood angle, the CHPs can be very instrumental in terms of educating the public on blood. They're actually the first point of contact with the patients in the field. And I think if the government can use them to educate patients, more so for blood, it can be a very big game changer. And I believe that, blood has a lot of myths in it. So many mythologies. People think blood can be used to, perform witchcraft or perform other things. So they can really educate. No, it can't. Okay. Just the myths. Just the myths. So they can actually be very, very important in educating the public on the use and the need for donating blood. Yeah, thank you.
Teresa, do you think CHPs are also helping you in your work in terms of just creating awareness and also just sensitizing the public on mental health, on substance abuse?
Thank you, Eric. Yes, the CHPs are critical kind of people within the community. And I know in the past we have trained a few of them. And part of what we have trained them on is on screening for substance use, because these are people who get in contact with the people at the community level, and therefore we have empowered a few of them on how to screen for basic screening for substance use, and also educated them on referral points for people who might be in need of addiction treatment and rehabilitation. And more so, they also assist in public education and advocacy, because these are people who are in contact with the community, and therefore they have, actually they are allocated a number of households that they are supposed to be working with. And therefore, if they identify that there are people in certain households that have got issues to do with alcohol and drug use, they can do basic screening and also refer them to points of service in the event that they require more help. Thank you.
Asante, there's some questions and comments here. Lenny says the blood accessibility is subjective. Someone who's not well placed in the society will struggle getting the blood. Otherwise, they'll find it's always available. If you are well connected and you have money, demand will be a word for the poor. And Basilica says blood is very vital in our facilities. We need a strategy to ensure we always have blood for those in need of it regularly, at the point of need. What do we do about that? You talked about technology earlier. How can we use that technology then to make it better?
Yeah, and I thank you very much, the people online, for those questions. I think it's critical for us to ensure that blood is available in our health facilities. And I think today we have technology that can help us enhance the efficiency of collection of the blood. There's so much wastage when you talk about blood. Sometimes blood is collected, but then it's not adequately processed, or there are no test kits, so blood is wasted. So we need a very, very well-developed infrastructure, vein-to-vein, as we call it, to ensure that blood is collected along the supply chain. And I think we in Terumo, we are investing in technology for blood processing and working very closely with the Ministry of Health. I must say that the Ministry of Health has also upscaled and is now going into full-scale automation. When you collect blood manually and you process it manually, you find that there's wastage sometimes. But if you process it automatically, then you find that all the blood that you collect can be used efficiently to the population. And one thing I'd like to say is that when you collect blood, in the past, you used to give blood as whole blood. So you collect whole blood and you give out whole blood. Today, you can actually process that blood into the various components. Mm-hmm. So platelets, for example, or red blood cells, or plasma. And 1 pint of blood can now serve 4 patients. So already by processing the blood, you can increase efficiencies by 4 times. Yeah, thank you.
Do you have that capacity in the country?
Yes, we have. It's newly ingrained in the Kenyan facilities. So the blood bank there, we already have put automated machines for processing the blood. So yes, it's available. Thank you.
Okay. Dr. Bharat Pandey, how can we make the cost of cancer to come down? What do we need to do to make cancer more affordable?
I think the most important step would be to reduce the burden of cancer by having effective screening. I mean, if you can detect the cancer early and you prevent the cancer early with adequate vaccination. Like there's a very effective vaccination for cervical cancer, the HPV vaccine. Similarly, you can protect yourself from liver cancer with hepatitis B vaccine. And if you reduce the risk factors which lead to cancer, like tobacco consumption, alcohol, maintaining body weight, and so many other things, then you can reduce the incidence of cancer. Coming to reducing to the costs, I think it will take a lot of effort from the government also to reduce the cost. Maybe they can subsidize cancer treatment for a period of 5 to 10 years. That's quite possible because most treatments do not complete the entire treatment because of high cost, lack of adequate insurance, and so many other factors. So I think there's a lot of work to be done on this aspect.
You've actually mentioned something that I touched on a bit earlier. Many patients come, they get the cancer diagnosis. Some will start treatment because at that point maybe they can afford it. Others will fall off because of cost. Again, we must find a fix for this. So you're saying one of the fixes would be government subsidizing some of these costs. How can they do that? Is it directly or indirectly?
Yes, I think this is an important thing that has to be done, subsidizing cancer and having cancer centers throughout the country and not only focused in the major cities of the country. Because many patients, they cannot travel to Nairobi to get cancer treatment. Some treatments like radiotherapy take days to weeks, so it's not possible for them to move away from their regular place of stay. Then this leads to loss of wages, incomplete treatment. So I think we need to have centers all over the country.
Okay. Dr. Rizwana, what do you think we need to do to just lower the cost of health across the board? I mean, there's all those things. One of the things that they'll talk about, even the government acknowledges, one of the barriers to accessing health is just the cost of health.
I think as we said, obviously subsidies is one way, but making health accessible and primary screening, more preventative, will make it obviously easier. Also having facilities, as we say, going up to the CHP level will be very useful. Today, technology is also supporting us a lot. Like I will speak to like for example, with a lot of AI, today we can empower the community health promoters, and this is a project we're actually going to be piloting in Maasai land, where we would use the Maasai community health promoters to actually use AI-driven portable tools, a little small slit lamp that connects to your phone camera, and get them to go door to door to try and get this prevention. So when you have it at the root level, you're already reducing the cost. However, if we don't invest more in that screening and early prevention and detection, that is when the costs start to go up, because then the treatment is of course prolonged, and this is where both the providers also get a strain as the patients do. I would like to speak to a little bit on even the cancer programs. Exactly what you said. There are some who will take to treatment, others drop off. Today, technology is coming in. I actually did see a machine that's treating certain types of cancers, where they actually take the radiation right at the source of surgery. I'm sure my colleague here will be able to say more. So what they're trying to do, and I saw this in South Africa, where they actually do the surgery, remove the cancer, come in and zap the cancer right there. So what then they are offering is maybe an 80% chance that even if the patient decides to drop off the radar, they may have a good hope of survival and at least a quality of life. So this is where it is headed. So I believe technology here can be a very big tool, instrumental in starting this up and helping us to bring down the costs so that we don't get to so many escalated levels of management of different disease patterns.
I would like to add a quick point here. I think if you start manufacturing, at least with regards to cancer treatment, if you manufacture the chemotherapy drugs within the country, I think we can certainly reduce the cost. Now, what is happening now, most of the drugs are imported from other countries, which adds to the cost. So we need to start manufacturing at least the basic cancer drugs within the country. That will definitely reduce the cost.
What do we need to do to have those manufacturing plants here?
So we should have good pharma infrastructure. That's very important. Manufacturing, it requires a lot of funding, lot of infrastructure, lot of support also from the government would be required to start manufacturing chemotherapy drugs in the country.
So it's more investment basically a lot of investment and a lot of concerted effort from across the board, government coming in and facilitating, investors coming in and putting in the money, and of course they want a return. They're in business, but also just creating awareness across the country and making sure that this spreads. So we have a UHC program that is being rolled out by government. We have all these talks, the starts, stops of it, what's working, what's not working. Do you think the industry is actually getting involved in inputting towards the universal health coverage? Universal health coverage is what we're talking about and we are rolling out and we're implementing. Is the health sector actually being asked to input? And this is to Nathan.
Yes, I think the industry can play a very big role in universal health coverage. And again, if I draw from the blood point of view, is that there could be no universal health coverage without adequate blood, also without adequate medicines. So medicines become very, very important in ensuring that patients are able to access these products. And there's need to reduce or increase local manufacturing, as my colleague has said, because if you have to import everything, it becomes very expensive to the country. And I think for blood, if again go to blood, I think it's one of the regions where we can be self-sufficient in a very short time. As you said earlier, blood is available in all our veins. It's just not in the right place in the hospitals. How do we get it from our veins into the blood banks, into the patients? So it's one area where we can be self-sufficient in a very, very short time if we put the adequate ingredients in place. And going beyond that, blood also can be a cancer medicine. We have what is called blood and cell therapies. So we can actually harvest blood, the stem cells, and train them to fight cancer. And that has happened in other countries, in the US, for example, I think in India, where they're very advanced. So I think with all this education, mostly through universities and research institutions, we can actually have adequate cell manufacturing in countries like Kenya. So I believe the government is hearing and is going to put investments in place to augment the local industry to produce more for the country.
Teresa, as we wind up this panel, our mental health issue, and that's leading into or causing drug and substance abuse. How do we address it?
First of all, I think as my colleagues from the medical field have talked about prevention, I think prevention is key. And prevention is through public education and awareness so that Kenyans become aware that actually most of the habits that they engage in actually end up affecting their health. And therefore we encourage and we keep on educating Kenyans on the negative effects of alcohol and drug use. And I think what is more important is to start at the very basic level, because part of the surveys that we carry out, I can remember in 2016 we did a national survey in primary schools. In 2018 we did one in secondary schools. And out of the findings, we discovered that now the age of initiation into drug use and alcohol use has moved from basically previously from 10, 11, 12 years to now 6 and 7 years. So that is a worrying trend that we now see young children starting to engage in alcohol and drug use. And partly this is being contributing by parenting. Because most of us, especially the middle class, find it stylish to even have a minibar in our homes, not knowing that we are actually exposing our children early, to substance abuse. And therefore, for example, the primary school study that we carried out in 2016, the outlier, the very youngest child in that study was a 4-year-old. That is a child in, I think, PP1. A child who said they have ever tasted alcohol, and that happened at home. And now in the secondary school study, one of the risk factors that students actually mentioned was in connection to parenting. That they mentioned that actually living with a parent, a single parent who is a father, was a great risk factor to the young people. Reason being that fathers, in our society, mostly it is acceptable for fathers to use substances. And therefore, when children live with a single parent who is a father, most of the time, if he comes back home, already intoxicated, he might not even be able to check on the children and see what they have been doing the whole day. And sometimes they stock alcohol in the house. So that alcohol that you leave in the house is what your children will start taking and add water into it without your knowledge. The other thing, of course, is about poor parenting. Most of us are working parents, and therefore we spend less time with our children. And therefore we are also running parenting classes, you know, among the general population, just to try and remind parents that even if you are a working parent, you still need to have time with your children, you still need to monitor, you still need to supervise their activities. And we go ahead and even ask parents, do you know the friends of your child? And go ahead and ask, do you know the parents of the friends to your child? Because sometimes families don't share values. And therefore, sometimes the children end up, you know, using substances or getting corrupt in other families when you have also tried and brought up your children very well. The other thing we see in our society today is about the emerging trends. Right now, we have the very basic, you know, snacks or confectionaries in our markets that are also laced with substances. For example, we have what we are calling cannabis edibles. We have weed cookies, we have weed cakes, we have weed lollipops, we have, you know, mabuyus that are also laced with weed or other substances. And therefore, it is important for parents to also ensure that we are aware of what our children are consuming, and that we also are advising that people should also come out as communities to also assist the authority by reporting, you know, cases or incidences of people who are actually peddling drugs or peddling or selling even alcohol to children who are under the age of 18. I think the other challenge that we also face as a country, and I know we tried one time to raise the age of use to 21, but it failed terribly in our parliament. But we know very well from a scientific point of view that when children get exposed to substances before the age, let's say, for example, 25, because the human brain matures at the age of 25. So when you get exposed to substances before that age, you are more likely to become addicted to the substances, and that's why we have a problem today, because most of the people start using substances early. Most of the students who are in universities right now are barely 25. Most of them are between the age of 18 and probably 22, 23, 24 thereabout. And therefore, that is why you find that when people start using substances, then it becomes difficult for them to quit. And again, the other thing is that treatment is also not very affordable in our country. It is very expensive to treat addiction. And again, the issue of comorbidity, you having a mental health condition, at the same time having a medical condition, at the same time having a substance use condition, complicates the treatment process.
We'll talk about the cost of treatment. We'll also talk about whether we have proper available counseling facilities, rehabilitative facilities across the country. But that's coming up after this break, when we now move and go and start our baraza, where Janet and Mariam have been organizing and have been talking to the people in the baraza. We'll be joining them shortly. And this is coming up in the next hour, Nation Health Summit at the KICC. Eric Latif, Janet Bogwa, and Mariam Bishar, we are here. We are raising the issue of health. How do we fix it? Non-communicable diseases, to substance abuse, to mental health, to having technology assist us in our blood transfusion services. All of them, to making sure that our eye problems are sorted out from the causal factors before we even come to sort out our eye issues. All that is what we'll be discussing next. Keep it here. Fixing the Nation, one conversation at a time.